Christine Schneider, the Visceral Voice.
Welcome to the Visceral Voice Podcast. I'm your host, Christine Schneider. Through this podcast, I aim to bring you the most current, up-to-date research on voice science, function, pain science, movement, and everything in between. I am on a quest to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, a movement specialist, and a manual therapist. Join us as we strive to provide current, knowledgeable, creative, and compassionate information to help you restore, regain, and create happiness and success on your vocal journey. Hello, everyone. Welcome back to the podcast. I am so excited that you are here today to meet my guest, Eloise. Eloise is a licensed massage therapist and a craniosacral therapist in Western Connecticut, specializing in working with people with hypermobility conditions such as the Ehlers-Danlos Syndromes. She is diplomat certified with the Upledger Institute and also a certified study group leader, a teaching assistant, and techniques examiner. So I know I've had many people, especially within the last year, come up and talk to me and say, I'd really like to hear more about hypermobility and certainly Ehlers-Danlos Syndrome on your podcast. So here it is. I'm so grateful that I found you, Eloise, and that you are willing to come on and have this conversation. So welcome and thanks for being here.
Thank you so much for having me. Appreciate it. Yeah.
Well, let's start, if you don't mind, just sharing your journey into becoming a craniosacral therapist and what made you interested in specializing in Ehlers-Danlos Syndrome.
So this is one of those things where it just falls in your lap. So I was a young mom looking for a new career and chose massage therapy. And from there, a friend of mine said, you have to take this class called craniosacral therapy. I could barely say it, let alone really understand what it was. And so I said, all right, I need my CEU, so I'll try this class. And I fell in love with it. The technique is so gentle, but has such profound results. And it's just consistent. Every time I work with somebody, it's consistent like that. Every class I go to, all the students, it's consistent. It's just such profound work, even though it's so gentle. So fast forward a few years after I started taking a couple classes, and my daughter started to have some medical complications, and she was a singer. She was a young kid, a triple threat in the performance industry. So she danced and she sang and she acted from a local program up here in Connecticut, and then she started to develop some very unusual things. And without giving too much away about what she went through, I realized, well, she finally got a diagnosis of hypermobility. The doctor didn't want to say for sure that it was EDS. It made no sense to me. He just didn't want the insurance company kind of freak out about it. And this is a story I hear from lots and lots and lots of people. That's also consistent. The storyline from people with EDS, their journey into getting a diagnosis is really challenging. Mm-hmm. And so I found myself in this position between two worlds. I had this skill set of craniosacral therapy, which is really well known for gentle work and helping the nervous system balance, to reducing pain and pain syndromes, to bringing better cognitive ability back into the brain. It recalibrates the central nervous system. In a nutshell, that's a nutshell. So all my craniosacral professionals out there, please understand it's a nutshell. And so I started to ask my colleagues and my mentors and my instructors, what do you know about Ehlers-Danlos syndrome? And I didn't get any real response back from almost anyone. Only one instructor knew anything about it, but I didn't know him very well at the time, and then didn't have much of a relationship with him. I didn't talk to him. I just came upon him later, and that's Fred Stallman, and he's been a big supporter of mine getting the word out. Anyway, so now I have these two worlds, and I'm trying to bridge the gap and bring knowledge to both to the EDS community about craniosacral therapy and how it could be effective for them in their management of their day-to-day symptoms, and to the craniosacral colleague world, manual therapy colleague world, where they are struggling to find appropriate techniques that suit somebody with lax connective tissue. Is a completely new way of thinking about the body, because most manual therapists work with a body that's working at increasing range of motion. And even in, I guess, singing, you would increase your range of I don't know all the words, of your range of your notes, what you're able to do. Okay, so it's in manual therapy, we try and increase range of motion to areas that are stiff. Well, we don't see that in Ehlers-Danlos syndrome. We see extreme laxity in the joints, and there are these areas that can become over tight because the body's so lax, other parts start to lock down. So there's a dichotomy there where you can be loose and hypermobile and unstable in a joint, and another area is too tight. So we have a whole different kind of system to work with. So I've slowly, chip by chip, just trying to get my colleagues a little bit more educated. It's slow going, but that's what I've been working on. So that's how I kind of got into it. I got into working with people with EDS through my daughter.
Well, I'm not grateful that she has EDS, but I am grateful that you were able to get into that kind of work to help this demographic, because it seems to be, and we were discussing very briefly before we came on, that we are seeing an uprise of diagnosis of EDS. I'm certainly seeing it more and more in my clinic. And I think the reason voice teachers are asking me at various conferences is because they're seeing it more and more in their voice studios. So to have information and to have someone like you and people like you who are helping to inform is very important for this demographic. So thank you for the work that you do.
You're welcome. I'm happy to be able to do it.
Yeah, thanks. So there are, as of right now, about 14 different types of EDS.
Yep.
And if we were to run down and talk about every single one, and maybe we could do that at some point and have you on and run through an actual series of episodes and interviews. But with these 14, if you don't mind just kind of mentioning maybe some of the more rare and then some of the more common.
Yeah, if I can, and I'll broaden that a little bit.
Yeah, okay, perfect.
So of the 14 types, all of them except one have known genetic markers. The one that doesn't is also the most prevalent, and that's the hypermobile type, abbreviated H, lowercase h, capital EDS. So it's abbreviated and said as heads. There are ongoing studies trying to find the genetic markers, and there's a lot of speculation about what we're going to find, but nothing's out yet. We're hoping this year maybe we'll have something from Norris Labs, and the Ehlers-Danlos Society hopes to have something out next year. Maybe like kyphoscoliotic type would be pretty rare. Brittle cornea syndrome is rare. More common, the top three are the hypermobile, vascular, and classical types. Those are the ones that a practitioner is most likely to come across. And among all of these types, there can be overlap. So someone with hypermobile type EDS wouldn't normally have extreme vascular issues like somebody with vascular EDS. which would be aneurysms and real serious vascular fragility and organ rupture and things like that. It's a very serious type of EDS. But there can be this delicacy in some people with hypermobile type. That doesn't mean that they have the vascular type. There's just sometimes a little overlap in characteristics. So that being said, the underlying issue with EDS is that it's a collagen problem, and collagen is the primary structural protein in the body. So wherever there's collagen, you can have potential for problems. Just kind of let that sink in a second. That's your eyes, that's your GI, that's your heart valves, that's your swallowing mechanisms and vocal cords. That's all of the ligaments that hold our bones together, the tendons that hold our muscles to our bones. So it just goes on and on
The
and
fascia, all of our connective
all of the
tissue.
fascia, yeah, I forgot. Right, all of the fascia. That's really significant. So that's how it boils down. Is a collagen problem. So it has the potential to really affect the body in ways that I sometimes will say are predictably unpredictable. So you just don't always know what might happen. But there are lots and lots of people with EDS who live a normal, very functional, very active life. And there are some that are truly bedbound because of comorbidities that they're experiencing.
Actually, if you don't mind, just kind of jumping into some of those. So let's stay with hypermobile EDS, just to narrow it in a little bit. So with hypermobile EDS, what are some of the comorbidities that one might experience or what we might find?
There's widespread pain. That's number one on the list usually for people. When I say widespread, it's like they will tell you everything hurts. It's not just a joint, it's everything down to the bones hurts. Moving hurts. Sitting for too long, walking too long, all it just hurts all the time. So pain management is really challenging. Joint instability, we normally would see subluxations or dislocations. Usually it's a subluxation where it's a slip out of a joint, or it's not quite all the way set. The joint's not actually set together quite right. It's not a full on dislocation, which is a complete separation of the joint and stays that way. So a lot of people with EDS will slip out and slip back in. So that shoulders, fingers, knees, kneecaps, patella, bones of the feet, the vertebrae, the sacrum. One of the big ones is the craniocervical junction, where the occiput, the back of the head, sits with the first cervical vertebrae. That can be unstable, and they call that craniocervical instability. Another term is upper cervical instability. So there's a lot. Those are joint issues. And then we have neurological issues, which can include Chiari-1 malformation or Chiari-2. So actually, sometimes it gets more just Chiari. We'll just say Chiari malformation, which is when part of the cerebellum, the cerebellar tonsils, and or the aspects of the brain stem slip through the skull into the spinal canal. That causes a wide range of symptoms because the cranial nerves are impacted. And for someone who's working with voice, since our cranial nerves control much of our upper airway and our voice and swallowing, if you have a client who's presenting with swallowing issues, you might want to try and send them to have an MRI and see if there's a Chiari issue. And it's pretty common, unfortunately, and no one fully understands why. So there can be that. And the other big one is tethered cord syndrome, where the filum terminale of the spinal cord, which is our anchor line of holding the spinal cord itself into our body, is too tight. So it's like if you literally think of an anchor line for a boat, and the anchor line is supposed to have some slack in it so the boat can move freely along the waves without floating away from where it's anchored. But if that bow line is too tight, every wave is going to come crash over the bow. The boat can't move freely. And so it causes damage to the boat, right?
Mm.
So over long periods of time, a tethered cord can go unrecognized and unrealized. And some of the symptoms involved with that are wide, just headaches, leg pain, weakness, urogenital problems, incontinence, things like that, pelvic pain, SI joint problems. So there's a specialist in Rhode Island named Petra Klinga, who a lot of people in the EDS community know very well, and she's tethered cord specialist. And so a lot of us, a lot of not us, a lot of the community will refer to her when it comes to tethered cord. And in the New York area, the man in the know is Dr. Paolo Bolognesi, who is out of Mount Sinai and has it's all he does is Chiari and cervical instability work.
Mm.
So there are a handful of specialists, but sometimes it can be challenging to get in to see them. And so diagnosis and proper care are really can really take a long time.
Yeah.
That answer your question?
Yes.
Probably missing.
Oh, absolutely. It answered my question.
Great.
Now, of course, with
sorry. Wait, no, I have more.
oh, okay. Absolutely.
I forgot. So then we could also have mast cell activation disorder or dysautonomia. Those are two great, huge, big ones I didn't want to forget. So dysautonomia is a dysregulation of the autonomic nervous system, and swallowing is affected, and speech is affected, and GI is affected, and cardiac function is affected, among other things. And mast cell activation, the way I like to put that, is a hyperactive allergic response to things. One of my experiences with that personally was that I broke out into hives while laughing. So it's an unusual hyperreactive response to what shouldn't really be causing a big problem, but it can cascade into lots and lots of other things, and inflammation and pain, and then can also look like dysautonomia. And Chiari can look like those things. So a number of these comorbidities can all cause the same problem. So it's very hard also to sift through all the comorbidities, see what's what, because some are treatable. If you can get your mast cells under control, then new presentations that are dysautonomia in nature or Chiari in nature can rise to the surface, and a clear diagnosis can come from that. All right. Okay. Sorry.
Now,
hanging in there with.
Oh yeah, no, of course, my pleasure. Is it common to see something like POTS with EDS?
Oh, yeah. Very common. So that's part of the dysautonomia picture.
Mm-hmm.
So POTS is for those listening who aren't sure about that, although you probably are, is postural orthostatic tachycardia syndrome. So when we stand up, our blood pressure is supposed to accommodate our posture, our upright posture, and when it can't, it doesn't rise in postural orthostatic tachycardia. Then the heart has to pump extra and raises in rate, so it's tachycardic. And people can feel lightheaded and faint and pass out, and then that can be also cause for more injuries or head injuries, and so it can be challenging.
Mm-hmm.
And gastroparesis too. They tend to go hand in hand because it's part of the dysautonomia picture.
Yeah. Wow. Coming back to the craniocervical instability, because a lot of our listeners are, of course, voice teachers and speech therapists. So we're talking about the occipital cranial base. And of course, there's a very important connection from outside world to inside world here with the myodural bridge of connecting into the dura mater. And I myself have had a major head injury about 5 years ago, to where I used to love having some nice suboccipital work, and now I cannot have that area touched.
Right.
And that is also similar when we're working with cranial cervical instability, of what kind of work we as manual therapists, but also I want to bring it up because a lot of our voice teachers give some self tools in a voice studio, which is great, but we also want to be mindful that there are certain demographics that some things are just not right for. So if you don't mind just expanding on that a little bit, and maybe some alternatives to some self-care around this area, as opposed to kind of having someone dig in with a tennis ball or some kind of tool.
Yeah, so when we have cervical instability, the ligaments supporting the head to the spine are lax. So it doesn't have the capacity to do that. So then what happens is the muscles get very, very, very tight. So if you're doing manual therapy, you find somebody who's all this tension and tightness in their upper neck and shoulders, and maybe getting headaches as well from some of this tension, but the instability itself can affect the cranial nerves too, which can also cause headaches. When that happens, our instinct is to break it up. Let's let that tissue relax. Well, that's the only thing holding the head to the neck. So we might not really want to relax those muscles. So it is a very tricky thing to work with. Working with a physical therapist who is extremely knowledgeable in EDS can be helpful. Mm-hmm. There's another person who I like to listen to and have done some training with, named Jeannie DeBon, who's out of England, who does an integrative movement method, which teaches body workers and often PT, whoever wants to take her class can take her class, how to bring appropriate and gentle stability to the body in a slow way without taxing it, but trying to redistribute tension patterns through the body to be upright and pulled together without being under hypertonicity or pain. It's a tricky thing to do with somebody who's hypermobile. So the integrative movement method is really effective in this way. So if you have a physical therapist who understands that to bring balance to tension instead of just releasing tension, and understands EDS, that is probably the best thing to do. I've heard that for some people, wearing a neck brace when they're traveling only can be helpful. That's just to protect it. But I have to say, you should check with a neurologist first. There are some people who don't like that people wear neck braces, and part of the reason is because now the muscles will start to atrophy and a client may become completely dependent on this neck brace. So that negates the ability then to get your own strength back and tensility in the body, proper tensility in the body. So unfortunately, I don't have a ton of great advice for craniocervical instability. The clients I work with are usually very symptomatic. Some can get neck braces and some can't. My clients will tell me their neck brace helps a lot, especially when they're driving. The clients I have who have not been able to get a brace really, truly suffer. So I personally am in a little bit of favor of a neck brace sometimes, but not all the time. Follow up with a neurosurgeon is probably a good idea. And just because you see a neurosurgeon does not mean you have to have surgery to stabilize it. Sorry, I don't have, it's a tricky one. Craniocervical instability is tricky. It's just tricky. And I'm sorry.
It is a tricky one. No, I think that's great. And I know some of Jeannie's work and some of the work that my colleague and I do at Performance Movement Restoration it's the idea of helping when someone has hypermobility, they might not have a lot of proprioceptive awareness.
Right.
So to help regain some awareness of where their body is in space, to help regain some of that proprioception, which is why the movement, that nice, controlled, slower movement can have such a profound impact, I think, for folks with hypermobility and certain, hopefully with EDS. Well, I know with EDS because I think she knows a lot about it, but she also,
Yeah, she has EDS and she has created her curriculum around it.
Yeah. So, in your experience as a craniosacral therapist, how do you see craniosacral therapy specifically really helping with this demographic?
It's very profound. It's gentle work. So there's no manipulation. So we don't manipulate the body. We work with the body and the body's inner wisdom on knowing what it needs in that moment. So every session might be a little different because the body's wisdom might need something different. Um, it can help calibrate the function of the central nervous system. So if you have dysautonomia, craniosacral therapy can help calibrate the autonomic nervous system so that you're not in fight flight constantly. Your anxiety comes down. Pain can come down if your anxiety comes down. So if we can kind of mechanically, quote unquote, because we're not manipulating, but it's a mechanical recalibration of the central nervous system by guidance of the body's inner wisdom. We can then bring a sense of, the client can then have a sense of peace. So there's potential then to take that peace and walk out the door and know that the body feels better, the mind feels better, the autonomic nervous system feels better, the pain feels better, subluxations are less, and be able to walk out the door and know that that can be achieved. The body can do that, has the potential to do that. It might need some other things to go along with it. And craniosacral therapy by itself isn't necessarily going to be as effective as pairing it with something like integrative movement method or other types of gentle physical therapy, or even bracing or taping or ring splints and self-care, things like that. So, but it can help bring down that. Most of my clients have some anxiety piece to with EDS, and I think that's really a primary response of the autonomic nervous system being dysregulated. But then when you're gaslit and you don't feel well, then you get anxious too on top of that. So it just cycles around. So if we can just kind of put a little break into that cycle, and then generally well-being feels well, it feels you feel better and can move on to the next day and the next day and the next day and more ease.
Yeah. I mean, getting a diagnosis is challenging, but living in a limbo of not knowing and seeing specialist after specialist that don't have answers that you're hoping to hear an answer from is unbelievably challenging. I have not had that with EDS, but I have certainly had that in my life when I was younger with pectus excavatum. So it's very hard to live in that limbo. Yeah.
Yeah. It's an average of 10 years to diagnosis for people with EDS. That's a long time of trying to figure out what's going on.
Wow. An average of 10 years. Wow. So you've mentioned how impacted the airway, the larynx, the pharynx can all be, and we can see in EDS symptoms of hoarseness and dysphonia and dysphagia, and vocal cord hemorrhaging. Have you come across this in some of your clients? And is this really common in a lot of your clients?
Yeah, I don't work with a lot of singers just because I know this is a singing, a voice podcast. So I don't work with a lot of professional singers. But yes, in a general aspect, I do see hoarseness, swallowing issues are a big one, choking all the time. And the thinner the material trying to be swallowed, the worse. So swallowing water is harder than eating a sandwich, because the muscles just can't control the thinner amounts of fluid, the thinner type of fluid. I have seen, when I first heard about this, I thought, this can't be a thing. But I've seen and heard of kind of a dislocated hyoid, and it can't really dislocate because it's a floating bone supported by slings of muscles and ligaments. It doesn't articulate with any other bone, but it can be displaced either left, right, or it can be retro, kind of in a retro like posterior position, and or jammed inferiorly or superiorly. So it floats. That means it can move in all the dimensions, and it can be jammed in one way or another, mostly because of ligament laxity or muscle tension. So you have one side that's too lax, one side that's too loose, and you have this very really crazy wobbly hyoid. And also I've seen that in the trachea as well. Very hyper. One client, unbelievable amount of mobility in the trachea. I was just stunned. So, and those are highly collagenous structures. So again, if we are if we do not have proper collagen structure, then functions of these systems can be impaired. And it seems that it happens like over time too. So you wouldn't necessarily see voice and swallowing issues until you're a little older in life. But I don't think that that's a rule. It's just appears that way.
Mm-hmm. Wow, I wonder if some of that has to do with as structures continue to ossify, other structures continue to get more lax.
That could be.
That is not that is not evidence-based. That is me thinking through of why that would be happening. But oh wow.
Yeah. Now in your industry, do you see things like Ehlers syndrome?
Yes.
You know what that is? So you might ask the people that you know with Ehlers syndrome if they're hypermobile, because the ligaments start to ossify from the base of the head to the hyoid. And some speculation among professionals is that it's ossifying to bring stability to the craniocervical junction.
That would make so much sense to me. I have probably seen Ehlers syndrome more than any therapist that I know for sure. I mean, I remember hearing about it in a visceral manipulation class, and there are phenomenal PTs and manual therapists in those classes with the Barral Institute, and pretty much no one in the class had heard of it. And I had already seen a number of people who had it. And I luckily heard about it very early on in my career, because some people are like, I just want you to get in there. And I'm like, no, that's not how I'm going to approach it. And luckily I had cranial sacral therapy very early in my career as well. So I had other ways of coming in and feeling around the structures with that sense of drawing it in the direction of ease, and without just going in and trying to manipulate structures when they're, if someone has double the length of a styloid process and what that would mean around the carotid bodies, that's very, very serious. So, and I think really important to mention on the podcast, because we do have a number of speech therapists now who do hands-on treatment, and really making sure that we understand what Ehlers syndrome is. We understand what ossification of that stylohyoid ligament, what it is for an elongation of the stylohyoid process, and what might be. I've heard a number of times that it could also be common in people who have had tonsils and adenoids out at a younger age. So there are questions that we can answer if someone's coming in and saying, I have a lot of ear pain, I have jaw pain, it's coming down into my throat. There are questions that we can ask to follow up and to say, like, is this appropriate for you? So thanks for bringing that up. So you had mentioned, I hope I get these names right. Petra Klinge and Paulo Bolognese.
Yeah.
So how important is kind of having this multidisciplinary approach when working with individuals who have Ehlers-Danlos, and what other professionals might you collaborate with that you want and and you have on your team to help support your clients?
Yeah, it's really important to have a multidisciplinary team. It's tricky to put one together, and it's hard to find a primary to kind of coordinate all of them. So that patients end up acting like their own primary in the coordination. It's exhausting. So if you're already tired, not feeling well, I have to do this. It's just hard. But other people that you could or may need on your team are cardiology and neurology. So Dr. Bolognese is a neurosurgeon, and actually Petra Klinge also is a neurosurgeon. But you would want to have neurology, and for some people, cardiology. Everybody should probably have a little foundational workup, cardiology workup, just to see if there are any abnormalities with heart function, or if there's POTS involved, just having, just getting a sense of where you are with your cardiac health. And I could just set a foundation. And then if something changes, you can go back to this person. So it doesn't necessarily mean ongoing all the time care with cardiology, but getting started with somebody would be good. So neurology, cardiology, pain management usually is also a good idea. Those are conventional. I also would recommend naturopathy, manual osteopathy. And so you can often find a pretty good manual osteopath. They tend to also treat the body as a whole. But you're looking for kind of a traditionalist, not an osteopath who's gone into neurology, although they would maybe have a different spin on things too, since they're taught from a holistic standpoint. A GI doctor and can be helpful. And a decent physical therapist that's willing to learn from you. So any practitioner you put in your team should have some knowledge of EDS. And if they don't, they should be willing and humble enough to learn about it, really learn about it and go to bat for you. And if you go in for an appointment and you're not really feeling like this person wants to learn from you, because as a patient, actually more usually than anyone you're going to go see. And then maybe it would be a good idea to find a different person. So I'm an advocate for that, finding the right care team for you. And they don't have to be experts from the get-go, but if they're willing to learn, that's golden. That's golden. And I'm a big proponent too, obviously, of alternative methods, alternative and allied health. So craniosacral therapy. But again, even within my own industry, you have to talk to a craniosacral therapist who knows about EDS. And if they don't, I'm happy to talk to them. I just send them my way and I'll tell them everything, guide them, mentor them, and, get them going. And then you guys will be a good team. Let's see, acupuncture, Reiki can be very nice because it's so gentle. It's just so gentle work. Meditation, listening to just 5 minutes of some kind of meditative music during the day can help also calibrate the nervous system and bring any anxiety levels down. And that's when I say anxiety levels, I should really not say it quite like that. When we recalibrate the nervous system, we're flipping the role of the fight and flight response and the rest and digest response. So most of us in an everyday world, we're living in our fight or flight all the time. And in people with EDS, it just doesn't seem to turn off ever. So if we can flip the roles, and so the rest and digest aspect of the autonomic nervous system is functioning better, which means that relaxation, that bringing the heart rate down, the breathing, the going to the bathroom better, all those things, we can bring those back into balance. Then naturally the fight flight response is downgraded and you're not living in that edgy place anymore. So anything that you can do that. And it can simply be 5 minutes of listening to some groovy yoga tunes on Pandora or wherever, and just is really helpful.
Mm-hmm.
So that's your list of practitioners, but also a little bit of what you can do for yourself.
Mm-hmm. If someone is listening to this and saying,
Mm-hmm.
this sounds like me, where do they begin?
If you don't have any practitioners yet, then talk to your primary. If you need a referral for seeing a doctor because of your insurance, ask for a genetics referral. Know that a genetics referral might take a long time to get. The Ehlers-Danlos Society is trying to get physicians of all backgrounds to be able to make a diagnosis and run genetics tests with some confidence. So they're trying to educate, but then there are a lot of physicians who don't feel like they can. It's not in their wheelhouse. So if you have a physician who's willing to run a genetics test for a connective tissue panel, great. If they're not, then try and see if they'd get you in to see genetics somewhere. There are a couple of EDS focused centers in the country. You can go to the EDS Society website and look for the Centers and Networks of Excellence. Here in Connecticut, our network includes a geneticist, Joy Samanich, Samanich. I might have messed that up. Sam. Sorry, Joy. If you so Dr. Samanich, she's in the Westchester area and she's in private practice, and her turnaround's pretty fast. And then at UConn and Yale, there are a couple of other geneticists, and sometimes it can take 6 months to a year to 2 years to get in to see them. So that's in our area. I don't know if I think Mount Sinai in New York City also has an EDS clinic or connective tissue clinic that people can maybe get in to see. Other areas include Mayo in Jacksonville, Indiana, University of Indiana, maybe Penn State at Hershey. So we're scattered all over the place. If you happen to be overseas, there are also some new places that have opened up overseas. But the best place to look for knowledgeable practitioners would be through the Ehlers-Danlos Society.
Mm-hmm. Okay, great. So you have a lot of educational opportunities for cranial sacral therapists, and we might have some or manual therapists, any manual therapist, anyone who is a licensed practitioner. Hopefully we have some listening. You have a training coming up in Maine in March. So I do want to make sure that people know about that and that you have time to talk about that. And then you also have some study groups that are available on your website. I have checked out a number of them. I highly recommend it. Even if you're not a cranial sacral therapist, there's a lot of information that Eloise shares in that is really informative and could be really helpful. So I would just recommend even checking it out if you are interested in learning more. So I definitely want to give you a moment to let everyone know where's your website, how to check it out. And you have a clinic, you're in Connecticut, and so I'd love to hear about your clinic information as well, if people can reach out and find you.
Yeah. So the study group videos that are on my website were specifically for Upledger alum. Sorry.
I'm just kidding. I said check it out, and then you're not allowed. I'm sorry.
if you're an Upledger alum, you can look at those videos. The reason is because they were an Upledger sanctioned study group. And
that makes sense.
Group. Yeah, sorry.
No, that's
they're available. I think I have 7 or 8 videos up there that go through. I recorded study groups that I ran about a year and a half ago. I haven't run them all year long. And we go through anatomy, we go through the different types of EDS, we go through the generalities of EDS, we go through techniques and how X technique might apply to somebody with X issues. All right, so we might talk about the sacrum and tether cord syndrome, and how to go through our techniques on releasing the sacrum and what then to consider if there's tether cord. Are there any adaptations we need to make with that? And I will also talk about Chiari, and I talk about all the neurological components, manifestations, because it directly affects our work, and how to best address it. So that's the study group information. Those are for Upledger alum only, and I do vet that. I do vet people who want to look at those. The workshop that I'm holding in Maine, that's in Brewer, Maine. It's from the 22nd to the 25th, 22 to 24. 3-day workshop. It's a roundtable and retreat, and I'm also introducing osteofascial integration, which is a compilation of all the things that I do. I'm putting it all in one place, and is now dubbed osteofascial integration. So I'll be teaching those paradigms and those concepts to manual therapists who want to join me in Maine. And this is like a 3-pillar class. So it's lecture learning. So you'll get a workbook, we'll talk, I'll lecture. It's a lot of information. You'll learn techniques, hands-on technique, experiential. But the biggest piece of this class that I love is the community of EDS people are invited to join us for a roundtable on one afternoon. And so as many people who want to show up can show up. I taught this in California last summer, and we had about 10 people come. So we're not looking at hundreds of people usually that can make it to this. And it's very, very profound for therapists to sit in a room with 10 or more people with Ehlers-Danlos Syndrome and hear one after another the story, the journey that they've all been on, what they're living with, what has helped them, what hasn't helped them. And it helps also the members know, they're not alone. So you hear almost the same kind of story. And it's really quite profound. And then those volunteers have also the opportunity to get treatment from the students, from the learning that they receive with osteofascial integration. It's very, very, very gentle work. You take a step back from the touch of craniosacral therapy, and we have osteofascial integration. So it's really, really blending with all of the tissues, from the osseous parts into the soft, delicate parts. We work with craniocervical instability. We work with tethered cord in a manner that is safe and gentle and light, and has been effective. So that's.
I have to look those dates. I can't remember when they are, but if I can't do that, I have to take this class at some point. So put me on your list, please. And then your clinic is in Connecticut.
It is in Connecticut, and to register for the class, also you can do it through my website. So the website is ctcranio.com, ctcranio.com. I'm in New Milford, Connecticut. My business is the Connecticut Center for Craniosacral Therapy, and it's just me in my practice. I have a nice treatment room. Everybody seems to love it. I'm in the Bleachery Buildings, which is an old warehouse system that was converted into offices along the little northern tip of the Housatonic River, where it meets Lake Lilanona. So I'm in a nice spot, and we have a great suite, and I have other practitioners in the suite, massage and Reiki, and it's just a nice groovy little spot.
Yeah.
Nice. And I'm available for anyone if they want to reach out and talk to me, so my contact information is on my website. Plus you can share my contact if you want to, through the podcast. So I'm an open book pretty much. Great.
Thank you so much. So I do want to mention just really quick, because I know you have a client that you need to rush off to. You had 3 hashtags when you sent in your guest inventory, and your last one, which resonates so deeply with me, is #YouCanHeal.
Yep.
And I just want to emphasize that with two manual therapists coming together who care a lot about helping people to get out of pain. Hashtag you can feel was so, I mean, this is the Visceral Voice, and I felt that hashtag so viscerally when I felt it. So thank you for that. I will make sure to include that in the show notes and, of course, when we post it.
Yeah, you're welcome.
So thank you for that perspective, too.
I have Instagram, too. Half the time I don't know what my hashtags really are, but it depends on the Instagram.
Yeah,
Instagram
and your
and
CT
Facebook.
Cranium, right? There? Okay, great.
And I have a really great person who puts it all together for me. Thank you.
Oh man, I need help.
I'll send her your way. She's fantastic.
Okay, yes, thank you.
All right.
All right, well, thank you. Thank you so much for being here with me, and I look forward to having more conversations with you.
Yeah, I'll look forward to that too. Thank you so much, Christine, for having me on board here. I really appreciated it.
My pleasure.
All right, have a great day.
Thank you all for listening. If you enjoyed this podcast, tell your colleagues, students, and friends. Subscribe, rate, and please write a review. You can find us on Instagram or Facebook, and feel free to check out my website at www.thevisceralvoice.com for information on programs and upcoming events. I hope you join us next time for another wonderful conversation on the Visceral Voice.